Welcome to The Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. Today we have with us Nick Desai, CEO and co-founder of Hey Renee. Welcome, Nick.
Thank you for having me. It's a pleasure to be here.
Awesome. Nick, tell us a little bit about yourself, your background, and what Hey Renee is all about.
Yeah, so I'm Nick Desai. I'm a first-generation immigrant from India, though I've been in the U.S. since I was 3 months old, and grew up in Southern California, the privilege of growing up in Southern California. Went to college at UC Irvine for electrical engineering, went to grad school at UCLA also for electrical engineering, and after a couple of years in consulting and trying some different things, I've been a serial technology entrepreneur. Hey Renee is my fifth venture-funded company in the last 23 years, and married my wife, Dr. Renee Dua, 13 years ago, and we now have three wonderful kids together. But 7 years ago, we started a startup called Heal, which is many of you probably heard of. It's a doctor house call, home-centric primary care company, which we built to operate in 11 states and raised $200 million in funding. In the first quarter of this year, we stepped out of our operating roles to really focus on exactly what you're about, which is reimagining the delivery of care. And that's what Hey Renee and the new company are all about. My wife and I live in the Pacific Palisades with our three rambunctious little kids. And I've always considered, and I truly believe this, and I'm not saying this, that the opportunity to work hard doing something you love is a privilege that very few people on this planet are afforded. And all we have to do is look at the refugees trying to get out of Afghanistan right now to be reminded of that, or the people at the southern border. They're coming here for opportunity, and we have it. And so Renee and I consider it really, if we don't do something with the opportunities we've been given. She's a physician, I'm an engineer. We grew up to affluent parents in Paradise and by the beach here in Southern California. If we don't use that to transform healthcare to help people, we're not fulfilling the opportunity we've been given. And that's really why we work so hard to do this.
Awesome. Well, I'm excited about have this discussion with you. You know, as I look at healthcare, and we talk about the transformation, I always start with the macro trend that I see. The macro, and this is all pre-COVID, right? There was the healthcare system pre-COVID, and although COVID has driven some rethinking of how we deliver care, but pre-COVID and still today, we have the same macro trends regardless of geography. Older, ager, sicker population, less doctors, less nurses.
Yes.
And the question is, and the reason that I'm passionate about the transformation, how do you deliver care when you have an older, ager, sicker population and less doctors and nurses and still get to a value-based care delivery system? So your thoughts on that?
Yeah. So look, I think that the macro trends you identified are absolutely the right ones, right? Americans are having less kids and living longer. We're getting older as a country, right? And within that, there's another trend, though. And less people want to be doctors and nurses, and we should talk about why in a second. But before we get there, there's another trend, which is I have parents. My father's 84, my mother's 78, my wife's father's 78, our mother's 72. You know what they want? They want to age in place. They want dignity and independence. They don't want to end up in an old age home. And frankly, they don't want to live with us. They want to age in place. And that is an incredibly important trend. And one of the reasons that I think President Biden is talking so much about home health work as a part of infrastructure, because it is infrastructure, because there's going to be a shortage of people to take care of all these older people. As they get from their 70s to their 80s and 90s, and they need help getting in the shower, getting their groceries, taking a walk, some people are fortunate to have kids who will love them and take care of them and let them do that. Other people will need home health workers, but technology plays a huge role in that. And the way that we know that is that technology already plays a huge role in the lives of all of us. My parents are 78 and 84. They're not particularly tech-savvy people, but they know how to order the stuff they want from Amazon. Right? For the last year and a half, they've not left their house that much because they're older and because of COVID, but they're able to get toys for their grandkids, my kids, and they're able to get their groceries at home, and they're able to get all their, sundries and toilet paper and all this stuff delivered to their house. And there are also less delivery workers available and less this available. There's less of everything available because as the population ages, there's less people in the labor workforce, right? So when we look at how Netflix or streaming services have made the consumption of content, my parents use Uber all the time when my father is too tired to drive. But when they use Amazon to get stuff to their house, those same principles can apply to make healthcare more easily and more effectively available to this aging population who deserves high quality care.
I agree with you. The home is absolutely becoming a setting of care, regardless of age. COVID actually, in my view, helped stimulate that to a degree because obviously the folks that are in greatest need lost even more access to care because of COVID, right? Can't go into the waiting room, shorter doctor's hours, had to find an alternative way of at least having a face-to-face conversation, if not driving a greater high acuity encounter, as well as remote patient monitoring for that matter. So the point there is that, okay, I am, my home is becoming a setting of care. How do I advocate as a patient? Because I have an 83-year-old mother-in-law. My mother was 83 before she passed of cancer. And, my father actually had complications of diabetes that I won't go into. But, certainly the home being transformed to a setting of care in the context of setting up a ramp, turning the dining room into a bedroom, right? Installing bathrooms on the first floor, right? Those are kind of some of the extended issues relative to home becoming a setting of care because I can't do steps. And it's quite frankly, sometimes the health system is too complicated for an 83-year-old to be the advocate versus always settling, if you will, for some level of service that is inadequate.
So look, I think obviously Renee and I started HEAL 7 years ago, which is a market leader in home-centric primary care, specifically because the home should be the center of your care delivery, not the hospital setting. One of the worst trends we've seen over the last 20 years in American healthcare is the death of private practices where doctors are giving up on the complexity of having to manage a practice and going to work in a hospital setting. They're becoming hospitalists. It's just cost, but it creates a shift mentality and reduces the personal connection. The things that come to our house that are not quite as good as if we went there. When you get Grubhub come to your house, okay, you got restaurant food at your house, but sometimes it's a little cold, it's out of a box, whatever. It's still pretty good, but it's not, you don't have a waiter serving you like you do at a restaurant.
Right? Exactly.
When a doctor comes to your house, it's actually better because a doctor can see your social determinants of health. And the only place to see social determinants of health, which are what determine up to 80% of health outcomes, according to Harvard Business School study going back 4 years now, is your home environment. What is your fall risk? Do you need a ramp? Do you need that bedroom downstairs? Is this more about the bedroom downstairs or about social isolation or about the fact that you're supposed to take a medication with milk, but you can't even afford the milk?
Right.
So when you look at the home, then you look at the potential of virtual care, because not everybody lives someplace a doctor can get to. They're too far, this, that, whatever the case may be. The virtual environment allows us to interact with a patient in their home environment, to couple some in-person interaction, because labs and physical exams have to still be done in person, with a lot of virtual interaction, with remote monitoring, with the delivery of goods and services, whether it's my vegetables, my medications, my virtual physical therapy, my companion from a service like Papa that might come to me and give me that companionship. Whatever the services I need can be brought to my environment where I can live and thrive with dignity, and I can be comfortable that I'm getting the care I need in the privacy and comfort of my own home.
But don't you think, let me challenge you a little bit on that, right? So I am in rural USA, not me personally, but I'm going to represent rural USA, right? And the doctor's in the city. The doctor may not be able to get to rural USA because it's 3 hours there and 3 hours back. It burns their entire day, right? But doesn't virtual care it really extend? Do you have to be in the home to be able to treat a patient in the home, if you will? So I always say you have to be seen by the doctor. You don't have to go to the doctor and vice versa, right? Doctor doesn't always have to go to the home. But what are your thoughts on that whole virtualization and how a doctor can maximize being seen by their patients without necessarily being face to face with them?
Yeah. So look, here's the key thing. There's no question that virtual care, if you live in Rapid City, South Dakota, or even more remote places, the only doctor you may be able to see is the virtual doctor, right? There's no question that's the case. But it's also the case that in 2020, 85% of the people who use telehealth services in the middle of a pandemic had a household income over $150,000 a year, which means they are likely to be more tech savvy, likely to be younger, likely to be in more urban or suburban settings than rural settings, right? That's just the data.
Right.
A lot of people in the rural settings don't even have internet access. So what we have to do to make virtual care work for those rural Americans is dramatically improve internet access, put the appliance in their house. We can't just assume we offered a service so everyone will figure out how to use their broadband and get on a Zoom call, right?
Right.
You have to be willing to put the tablet in their house that has the 4G or 5G connection that with one button to touch, saying, you want to talk to a doctor? Hit this button. It's as simple as that, like a TV remote. How is it that every senior knows how to use their TV remote? Because they like to watch TV. It's worth the effort to figure it out. So we have to make it dramatically easier. But if we do, then telehealth combined with remote monitoring, advances in remote diagnostics can dramatically improve the care that rural, underserved, and it's not just rural, underserved, lower income Americans are getting, right?
Right.
I know of insurance companies, sadly, that are selling insurance plans in the quote unquote bad parts of cities like Chicago that will not allow doctors to go into those areas, or they discourage their doctors from having practices or house calls in those areas. That to me is almost criminal. But the point is, those patients deserve great health care too, and virtual care may be a way to get it to them. Now, where innovations are needed is some things require human touch. Administering a COVID vaccine is a great example. Drawing labs, some parts of physical therapy. You end up in a hospital, you need a nebulizer treatment, okay? I know a senior right now who has a nebulizer at home. His daughter happens to be a physician. Most people don't have a daughter who's a physician. They don't know how to set up the nebulizer, right? So we're going to have to figure out how to train a class of workers that can solve the last mile problem while most of the care is being done virtually.
And so all the more reasons why, if you do have kids, you should encourage them to be a doctor or nurse, because you will get old. And my son always tells me that he is the one that's going to sign the papers to put me into the nursing home. So, yeah. But a little bit of encouragement to increase the number of doctors and nurses as the population grows. Seriously, how does Renee change the model in the context of serving that home? What's your vision?
Renee is Dr. Renee is my wife. And she changes it by founding a company with me called Hey Renee. Here's how Hey Renee solves that problem. I was trying to be funny, but that's
okay.
Anyway, before I answer that, let me say something. You mentioned at the onset that healthcare is way too complex for seniors. It's also way too complex for doctors and nurses. One of the most important reasons they're leaving, there are three. Right now, it is because it's a thankless job where maskless idiots end up in your ER and are attacking you while you're trying to save their life. And it's not enough money to do that. The second reason is even pre-COVID, you can spend 12 years to become a doctor and make $250,000. And that might sound like a lot of money, but that person is smart enough to spend 4 years in school to become an engineer, work at Google and make $350,000. It's a lot less school and they're smart enough to do it. Right? The people who become doctors. But the third reason is because the stuff, a doctor sees you 3 or 4 times a year. They make a recipe. They say, here's what I want you to do. You have obesity, hypertension, diabetes, and untreated depression. You're an average 75-year-old American. That's 70 million people right there with those conditions that I mentioned. Okay, great. You need to take benazepril for your blood pressure. You need to measure your blood sugar 3 times a day. You need to see a mental health professional. You need to get your labs drawn once every 3 months, et cetera, et cetera, et cetera. You need someone to help you bake that cake, and they need someone to help you bake that cake because 60% of doctors don't have the time to coordinate the care for their patients.
Well, that is exactly right. So, I always say if you take a look at the average Medicare patient based on CMS documents on their website, the average Medicare patient with 5 chronic diseases sees 9 different doctors in a given year. They only spend 15 hours in that year in front of their doctor. The question that you're raising is, what happens and the other's 8,745 hours. And then how do I, as the patient, become engaged and not get lost in a very complicated system, especially with all due respect to the elderly? I'm 83. I don't get the complication, right? And therefore I am challenged, and therefore I give up. I'm just going to sit and watch TV and let it happen.
Resignation, interestingly, it's interesting that you did the math. I've done the math too. And it's actually, I always say it's 8,756 hours that you're not with the doctor, because most of those 15 hours in a waiting room. There's data just today that the average in-person visit is shorter than the average telehealth visit now, right? It's about 10 minutes long. So you're spending about 2.5 hours with doctors and about 8,756 hours without. And not only do patients give up, but the doctors give up because they can't get the patients to do what they want. And the system isn't set up to compensate them for doing that. The system is set up that you have to have a bigger census to make money. So Hey Renee comes in to solve both those problems. We are a patient-centric digital best friend who takes that recipe from a doctor without the doctor having to do any extra work and bakes the cake for the patient. Your doctor said to get benazepril. We're going to get it delivered to your house and then remind you to take it. Your doctor said you need help, mental health. You're a Spanish-speaking person who lives at home and doesn't drive. We're going to get you set up with an in-network teletherapy provider, telemental health provider that is Spanish-speaking. We're going to do single sign-on. So all you have to do is click on one text message. You don't like apps and digital interfaces? Great. We're going to speak to you through Alexa. You don't have internet connection in your house? Like 48% of seniors who are on Medicare Advantage plans don't? Great. We're going to put the tablet with the 4G card in your house. So we are going to become that best friend that coordinates, communicates, and connects all aspects of your healthcare. And in doing so, we're going to remind you to measure your blood pressure, but then we're going to take that data point and send it to your doctor and say, this person's blood pressure is dangerously low. Do you want to call them before they end up fainting and in the ER, because that's where the cost is? We all know that the cost in the healthcare system, 35% of the $4 trillion we spend goes to hospitals. Another $1 trillion goes to bureaucracy and administration. Those are the costs we're directly attacking by simplifying and demystifying healthcare in a patient-centric, friendly way.
Interesting. If you're just tuning in, you're listening to The Virtual Shift. I'm your host, Tom Foley. Today we are speaking with Nick Desai, CEO and co-founder of Hey Renee. So many interesting points there, Nick. So how do I, as a patient, or how do I, as a provider, engage a service like you? Who's your customer?
Our customers are any risk-bearing entity. So it could be insurance company, obviously. It could be a managed care plan, a health system, a direct contracting entity, even an individual doctor's office. If you own the risk, the financial risk for these polychronic Americans, the people you mentioned, 2 to 5 chronic conditions, 92% of the healthcare cost, 100 million Americans fit into that category. It's in your interest that people take their medications, make their appointments, track their vitals, get help for their mental health, and we help you do that. So those are the people who pay us. Our service is going to be always free to the consumer. But one of the key things we realize is that insurance contracts don't equal acquired patients. Insurance companies and health systems are not getting good at getting their patients to adopt new technologies. So we have to call the patient directly. And that's a key part of our thing, which is we're actually going to call patients and say, hey, we've got this great tool that's going to help you do all these. You have trouble getting because you know what seniors talk about? You know what these patients talk about? They don't talk about HEDIS and care gaps, and they don't talk about their RAF scores and MER.
They don't?
No.
Oh, I'm sorry.
They don't talk about any of the stuff that the healthcare. You know what they talk about? I want to play with my grandkids. I'm supposed to pick up a medication, but I don't want to bother my son to take me. I want to be social. The census data put out that the villages in Florida, where the retirement community is the fastest growing zip code in the census in the United States. That's where more people are moving to than any other part of the country. Seniors want to live their life. They don't want to be treated like patients. They want to be treated like humans and live more human life with more dignity. That's where we think we can truly succeed.
Obviously, you talked about the use of technology. I always, myself and Jeannie MD, when we talk about remote patient monitoring, we often don't talk about it in the context of technology, right? Because the technology is not the solution. The technology is the underpinnings, but you really need to have a program, right? Remote patient monitoring program. So if I'm a diabetic, if I'm cardio, if I'm respiratory, if I have a need in those areas, it's really about how do I marry clinicians, coupled with a wellness program with technology to ultimately help produce, allow that patient to move on this path from awareness to wellness. So would you agree with that general assessment of
Yeah.
it's not about technology?
Yes, I would. And I will say also that if you look at the use of innovative technologies, it's the application and the value that drives the use. It wasn't so much the iPhone itself that caused an explosion and a cultural tectonic shift in how people use their phones. It was a front-facing camera. So the word selfie was invented. People started taking pictures of themselves. Instagram, YouTube, Facebook, all these platforms are driven by people. TikTok are driven by. And similarly, I look at remote monitoring and I say the technology is cool. It's going to advance. It's going to become more ambient and embedded and whatever sensors. But it has to be that the healthcare community thinks about remote monitoring as a part, and I'm stealing my own wife's logic here. She's the one who always says this, as a part of preventive care. Right. It's not that I want the vital signs once you've had a heart attack. I want the vital signs that helps me prevent you from having an acute episode.
Exactly.
I want to be able to use them, not so I'm inundated with alerts every time your blood pressure is 2% higher, but so that in the context of care delivery, it's the background things that I am doing as a clinician. I'm not a clinician, but a clinician might do, reacting and proacting to changing data to help that patient, where a patient might even know that they got the help, right? I changed the dosage on this medication, I upped the this, I did the that, so that your vitals are trending in the right direction. So all you know is that you wake up with more energy, you're able to get out of bed, play with your grandkids, go on your date, and live your life.
You know, you're raising a great point, and that is that, you know, in this remote patient monitoring world that is just beginning to develop, in my view, COVID drove telehealth from being a nice to have to a must have. And then and now it's realizing, hey, telehealth is more than video. If your wife was on the line here, I'd say, are we in a telehealth session right now? Because I got a doctor and a patient on opposite sides, right? So I look at, I don't look at Zoom, frankly, with all due respect to Zoom. I don't look at that as a telehealth platform because there's much more from an end-to-end platform that you need to have to provide that virtual care. So the point there being is, but you're talking about data, and data ultimately is king in the context of healthcare. How do we collect data through medical devices, FDA-cleared medical devices, that allows us to at least proactively monitor, to your point, at the right point, a doctor can step in and say, hey, stop eating that jelly donut because your A1Cs are off the charts, right? And because, you know, a lot of things don't hurt. Yeah. Hypertension doesn't hurt. Diabetes doesn't hurt, right? A lot of conditions don't hurt. And that's the only time when a patient really says, I got a toothache, I'm going to the dentist, right? Versus brushing your teeth every day. And I can tell you, my father was a diabetic. He was obese. So, but the last 5 years it hurt because you lost both legs and an arm. You know, you really have to be careful about making sure you listen. Mm-hmm. But that was in 96. Now we're in 2001, 2002. That data ultimately becomes the king in the context of helping you, the provider, and helping me, because even though I have a provider that's monitoring me, I still need a coach. Yeah. Right. And that's where maybe Alexa comes in some context of you just took a measurement, your blood pressure is good, keep up the good work versus stop eating. You know what I mean? Thoughts?
Couple points to that. Today, we're at a point where your sign, the one behind your head here, says Reimagine the delivery of care. Right. And we actually have to dramatically reimagine it. And I'll say it in two important ways, right? The first of all, just to your coach point, I always say you don't even need a coach, you need a personal trainer. And the difference is a coach tells you what to do. The coach is the guy at the end, or the lady at the end of the thing saying, go run 40 laps. The trainer is the one who runs them with you, right? Right. People need to have their hand held along their journey and to stay motivated. And that's where we hope to come in as Hey Renee, to become that. That's why we call it a digital best friend, because it has to feel not like medical guidance, but like a helping hand. And every day you feel the impact and the support of this digital entity that helps you along your way to better health, and you feel it. But interesting. The broader point is that we have to rethink the entire delivery of care. It should not even be called telehealth. It should just be called healthcare delivery. And doctors should be about the magic of the expertise. They should not spend their time doing things other people can do in a shortage of doctors environment. They should spend their time doing things nobody else can do. And we did that. We've done that in dozens of industries, right? And the way that I know that is the magic of Amazon is not that I can order a Nerf gun for my kids, or not that someone can deliver it to my house, because those things existed. Sears had a catalog and it would come to my house. The magic is it comes to my house the next day. And that happens because they took the really important parts of it and they had really smart engineers write extremely sophisticated software code. So a robot will go pick something out of a warehouse, drop it in a thing, put it in the right truck, and a few barcodes, it's at my house. And it's almost always phenomenally correct when you think about the number of deliveries, right?
Yeah, I'm with
so
you.
Why are the doctors not? The transformation that needs to happen is that doctors are using data proactively, population health and individual health data proactively to educate, inspire, and guide their patients and provide the expertise so that a layer of machine and human coaches and trainers and phlebotomists and whatever can do the other parts of the work so that we're not as reliant. A doctor doesn't need to measure my temperature. We need to rethink this entire thing so that healthcare is a data-driven, proactive care in my life. Just like when I go on to Amazon earlier this morning to order something, it popped up and reminded me that I'm probably going to need toothpaste because it knew the last time, and I just hit one button in the toothpaste. I've never been out of toothpaste or toilet paper or diapers.
So let me ask you a question. I don't disagree with anything you said. We definitely need to transform the delivery of care. The challenge here, do you think the health system as a whole is disjointed, and do you think we'll ever get there? And where does regulatory come into play? Your thoughts?
Well, I'm an optimist. I wouldn't be in this industry if I didn't think we were going to change it. And there are a lot of very smart entrepreneurs that are fundamentally paradigm shifting the space. But we have to remember that there's an oligopoly of hospital systems in this country, and they are the ones resistant to change. People always talk about big pharma. Big pharma is 10% of the healthcare cost. Hospital systems are over $1.2 trillion a year. That's where the costs are. We got to break their stranglehold on the patient, on the doctor, on the delivery of care, to bring it home-centric, to use technology to reinvent care paradigms. And I'm personally a believer in Medicare for all because it's the most efficient health insurance system in the country. I always say this, that insurance fundamentally doesn't work for healthcare because the model of insurance is people don't use the service, right? That's why life insurance works, because when I buy life insurance, I don't want to die, and my life insurance company doesn't want me to die. And if I buy fire insurance for my house, I don't want my house to burn down. Healthcare should be like education. We should want people to use it. We should want people to use it earlier and more frequently so they don't use it for the really expensive stuff only when they're really sick. And that's the system that we have to break the stranglehold of. But I do think you're going to see a tectonic shift over the next 3, 5, 10 years, partly based on government action, partly based on skyrocketing costs, and partly based on the number of smart entrepreneurs that are dramatically altering healthcare in America for the better.
Awesome. Nick, great conversation. I really do appreciate it. And I wish Hey Renee all the success in the world. Thank you.
Awesome to be here. And if you're at all interested, check out heyrenee.co.
I would like to thank the show sponsors, both HP and Intel. HP Engage long lifecycle products provide the stability, safety, and security you need, plus flexibility and performance designed for today and tomorrow. As well, Intel would like you to know we're going above and beyond together with new standards for business with the latest Intel vPro processors, delivering what IT needs for performance, security, remote manageability, and stability. And be sure to check out the program page on healthcarenowradio.com. And remember, connect or follow me on LinkedIn, Twitter @FoleyTom, and follow the show's hashtag, The Virtual Shift. I'm Tom Foley. Until the next shift.